Thank you, Mr. Chairman. Hello, ladies and gentlemen. I have nothing to declare. Today, I'm going to talk about two topics. The first topic is new surgical approaches for THA, especially focusing on MIS. The second one is smart tools, including CAS and Dupes' new instrument, the Kinsize. I cannot tell you about the whole detailed procedures because time is limited. Recently, there has been a trend toward minimally invasive surgical procedures for rapid recovery. In this regard, the direct anterior approach has attracted much attention by orthopedic surgeons and patients all over the world. The first written description of the currently used anterior approach to the hip might be attributed to Carl Huiter. The DAA enters the hip joint through the intermuscular interval between the TFL and gluteus medius laterally and the sartorius and rectus femoris medially. Compared with the posterior approach, the DAA is considered to be a true intermuscular approach that preserves the soft tissues around the hip joint, thereby preserving the stability of the joint with a lower risk of complications. The DAA can be performed through a longitudinal or skin crease bikini incision. There is a special table, such as HANA table, for the DAA, but surgeons can do it on the regular table. As an anterolateral approach, Röttinger introduced a modified Watson-Jones approach that utilized the plane between the tensor fascia lata and the gluteus medius muscles. Compared to the direct lateral approach, it offers the same advantages of this approach while avoiding iatrogenic abductor injury. Supercapsular percutaneously assisted total hip, so-called SuperPass approach, is total assisted MIS-THA without hip dislocation, using the interval between the piriformis and gluteus minimus. It can preserve the hip capsule and the external rotators. After intramedullary rimming and broaching of the femur without hip dislocation, osteotomy of the femoral neck is performed with the brooch as a sole guide. Acetabular preparation and cup placement should be performed using a cannula through the additional porter posterior of the femur. Frankly speaking, it's my personal opinion, but it seems a bit weird. The direct superior is a posterior approach that spares the iliotibial band, obturates the external tendon, and quadratus femoris muscle. ITB plays an important role in maintaining pelvic stability during functional activities, specifically during gait. Therefore, the DSA may enhance postoperative mobility and lower the risk of dislocation. To perform MIS-THA, special instruments are needed, such as an offset reamer, offset impactor, and curved or dual offset recip. However, many studies have reported high complications with MIS-THA. For example, the disadvantages of the DAA include a steep learning curve, radiation exposure, wound complications, nerve injury, and early implant failure. There is considerable marketing and promotion of the MIS-THA within the orthopedic industry to popularize the procedures. Marketing has produced biased claims of superiority without the support of peer-reviewed literature. The MIS-THAs have inherent pitfalls that may even be considered complications of the approach. According to a recent paper from the American Hip Society, 43% of the previous DAA users had abandoned it, and only 23% of all respondents believed the positive evidence of the DAA. I'm a posterior guy, and I don't use any new surgical approaches, but try to reduce soft tissue injury recently. With experience and familiarity with this old approach, skin incisions can be minimized to 6 cm in some patients. So conversations about the approach sound like a religion rather than science. The next topic is about the smart tools for THA. To improve precision and accuracy in component placement, novel computer-assisted technologies such as computer navigations. Many kinds of robotics have been developed to reduce the incidence of THA-related complications. Despite multiple studies demonstrating the increased precision and accuracy of component placement in THA using both robotic-assisted and computer navigations, there are still controversies about the clinical usefulness. Even in a recently published paper, computer-assisted surgery has not necessarily translated into better short-term patient outcomes. Previously at the ITA symposium, I have talked about cons of cows in primary THA. At first glance, robot arm-assisted THA looks very attractive. We can imagine the robot arm can ease our physical strength. But in real practice, it's still hard to hammer, even with a robot arm assistance. The robot arm cannot protect us from musculoskeletal injury smartly. Surgeons are known to hammer an average of 300 times during each THA case. That's a lot more times than we expected. Let me introduce a smart surgical automated system called Kinsize, made by Synthesis. The Kinsize system is designed to eliminate the need for repeated mallet use. There may be less surgeon fatigue and potentially fewer work-related injuries in the operating room. Standard femoral preparation with a mallet requires multiple strikes on a broach handle. Each strike varies according to the direction of the mallet. These off-axis blows produces energy out of plane with the overall direction of movement. The Kinsize system allows that energy to be delivered in a collinear direction. This smart tool provides consistent and controlled energy delivery. This allows for constant delivery of power to automate bone preparation while making the surgical procedure simpler and easier for the surgeon to perform THA. This is a short video demonstrating the usefulness of a Kinsize system. When performing THA on the left hip in lateral decipitatus position, it's not easy for the right-handed operators to hammer behind the patients. However, surgeons can easily place the acetabular cup in any position by just depress the trigger of the Kinsize. Auditory feedback with a higher pitch change will often be received when the cup is fully seated. There is a sound problem. Okay. As compared to auditory or tactile feedback that accompanies the use of a mallet, the feedback from the Kinsize system during the femoral preparation is visual. When the ultimate broach is fully seated, the broach progress slows significantly and will stop advancing despite continuing to hold the trigger. Let's see the final broaching. There is no movement at all at the final broach. This is one of the funniest videos when Googling orthopedic surgeons, but we can look cool and smart with this device. From a different point of view, we orthopedic surgeons need more smart tools that make THA easier and simpler without unnecessary additional procedures or the risk of new complications. Thank you for your attention.